Welcome, Dr. Cherpak. Thank you for taking the time to chat with us today. We get a lot of questions from new customers asking us for guidance on steps to operationalize their new 3D printed bolus or brachytherapy program. And your center has been using 3D printed accessories for many years now. So our conversation today will focus on the steps your center took to implement a 3D bolus program. Before we begin, a brief introduction. Dr. Amanda Cherpak is the Director of Clinical Medical Physics at Nova Scotia Health and an Associate Professor at Dalhousie University. She holds a PhD from Carleton University and has been working in clinical radiation oncology physics for over 10 years. Her research interests include novel imaging techniques, adaptive radiation therapy, and 3D printing applications in brachytherapy. She is a member of Variant's Intelligent Imaging Consortium and is a co-investigator on Nova Scotia Health's Hypersight, breath hold, and head and neck clinical trials. Dr. Cherpak, welcome, and I'll hand it over to you.
Hi, Erin. Thanks for having me. So maybe I'll start off just giving people an idea of our center if they're not familiar with Nova Scotia Health or QE2. So we're located in Halifax, Nova Scotia. We have a population just under 1 million people. We treat just over 3,200 cases per year. We're, like I said, located in Halifax. We do have another site in Cape Breton, which is about a 4.5-hour drive away. So here we have 12 medical physicists, 7. Actually, we're growing beyond that now. We've hired a few more dosimetrists, 4 electronics techs, 1 physics assistant. We have over 60 radiation therapists and about 14 radiation oncologists. So far as equipment, I always like to know what people have at their center to kind of understand how we can implement different things that they're doing with what we have. So we have 7 linear accelerators, mostly true beams. We have 2 true beams that can do stereotactic treatments. We also most recently acquired an ethos system with Hypersight imaging. CT Sim, we also have very active HDR brachytherapy program. Also have an ortho voltage unit. So far as software, we run Area. We've had version 15.6 for quite some time and just recently upgraded to version 18. Velocity, and clearly we use adaptive 3D bolus. So far as techniques, we do SRS, SRT, a lot of different sites for SBRT, motion management, and also so far as our graduate program, we have a thriving research group here for master's, PhD, and certificates. So a lot of people that can help out with different projects that we have. So maybe I'll just start off by showing a few of the high-level topics of what would come to my mind for a center that's first starting to implement 3D bolus and taking you through some of the steps that we did. So our processes have changed over the years. I think when people start, they'll probably do a lot more measurements and a lot more imaging and a lot more consults. And then as you get more comfortable, some of these steps might fall away. But to start off, physics evaluation. So we like to really dig deep into the different tools that are being used and really understand and also qualify the information that's coming from a vendor or coming from external QA procedures. So first of all, any new material, particularly bolus, we'd be interested in doing an HU assessment. So to really understand, it might be coming with a given density or a given HU, but we're going to want to, trust but verify. So maybe that means doing some test prints, doing some CT scans, doing some test planning. A lot of these anthropomorphic phantoms that you have can be very valuable. So ones where you have the shape of a face, to go over complex geometries or maybe a chest wall. So, looking at test scans of those, designing different boluses, getting a sense of how that all works, and then printing things and really looking closely at the materials. At the beginning, we did a lot of different measurements, both on phantoms and on patients. Some people might be familiar with this original study that our Chief of Physics, James Robar, did, along with a lot of different stakeholders. So if you look at the list of authors here, we have radiation therapists, we have a physics assistant, we have other physicists, we have dosimetrists, radiation oncologists, graduate student. So that really kind of points to the variety of people that are involved in something like 3D bolus. So with this study, this was a comparison between regular sheet bolus that would have been the standard at the time versus 3D printing. So maybe to a lesser extent, this might be something that people might be interested in if they want to verify for themselves how things work in a clinic. We used both and alternated with patients, but you'll see there's some pictures of OSLDs, so taking measurements. Maybe you want to measure with 3D bolus compared to your current standard, not even to compare to a treatment planning system, but just one versus the other. So, if this is what patients get right now and you're going to switch your technique, you might want to be able to show if there are any differences or, if it's the same. And also the picture in the bottom there shows the differences in fit. So this is a great one to show to your colleagues to explain something like 3D bolus, how it can be so much better. We all hear at the units troubles that the therapists have, fitting non-customized boluses. So this shows a great example of where it fit really well. Next, if we think about clinical planning, so, physics, I picture us doing a lot of this groundwork and getting some of this background information, and then you want to bring it to your bigger site group. That's how we're organized here at our clinic. So, for breast, head and neck, skin, we have different groups that'll meet semi-regularly, and that involves everybody that has to do with treating those different sites. So your radiation oncologists, therapists, in this case, particularly those who work on your CT, dosimetry, physics, really everyone in this list is going to be involved in something like 3D bolus. So coming to these site groups with, this evidence or an idea and proposing how it might look like for clinical implementation. Some of my suggestions or things that I think would be keys to success for implementing something like this would be you really need champions. So, you might have 4, 5, 6, 10 physicians treating one site, but, if you get some buy-in from a few of them or some buy-in from, some of your dosimetrists or the therapists, you don't need everybody to be hearing about it for the first time all at once. But if you kind of work with a smaller group and get these champions who will promote it and, think to use it and implement it first, it can really help adoption on a wider level. Come into these larger groups, so something like a site group, it really helps to come armed with a proposal rather than just a vague idea. So if you have an idea of how it might be implemented and the steps it would take, then people can certainly chime in with their different points of view and things that, certainly I might not think of as a physicist, but at least you now have a skeleton plan of how it might be used, and then you can kind of tweak things as it goes. And also it might work to kind of start small. So maybe the proposal is to start with a few patients or, a few tricky cases where it would really be worthwhile looking towards kind of bigger expansion, if that makes sense. And then some other things that you're going to want to talk about in those initial conversations too would be workflow. So how does this differ from your current workflow and the current way that things are done? Going right back to the beginning to like identifying those cases where it would be most useful, what physicians think and, the therapists and where they find difficulties in fitting regular bolus or where it's not doing the job. Also to talk about fabrication. So if using adaptive on demand and, you're sending in the orders, kind of practice, maybe do a few test cases, look at, is it going to take a couple of days? What does that look like? How does that fit into your current workflow? CT scanning. So, you have that initial CT sim appointment. Are you going to have to bring the patients back and scan them again with the bolus? Or if not, what does that look like for setup on the unit?
In terms of making those decisions, who would typically make those? Would it be the site group or would you have specific leads identified to do that? What's your experience there?
Yeah, so I think, there's some sites that, kind of make sense to start with. So like breast, chest wall, head and neck, skin, and then within that group, I think it really probably depends center to center. For us, we have some radiation oncologists who really do understand the benefit of 3D bolus and they're very progressive and they'll think of it and they'll be the one requesting it. That initial CT sim appointment is a really crucial decision point as well because, these therapists, they see these patients every day. And in our clinic, our therapists who are at the CT, they rotate through through when they were on the unit. So they can predict what patients are going to be tricky. They can predict what geometries are going to be tough. So their opinion is very valuable so far as requesting 3D bolus compared to what the standard is. So them, and then also once it gets to dosimetry too, and they have a look at the plan, and if they start struggling or they can just see where 3D bolus would work really well, they can also request it as well. So really kind of relying on the expertise of these different people, and then also empowering them to make that decision, you know. So if the radiation oncologist requests it for some specific reason, to really understand that they would have their reasons for doing so, which might be different than what your therapist at CTC versus what might be different in dosimetry, you know, but everybody has a different point of view. So it's just important to really empower all these different groups, I find.
I got one more question for you.
Yeah.
You know, dealing with customers all across the states and whatnot, they often have different protocols and procedures when it comes to immobilization for head and neck in particular. And when to, you know, design your bolus. Do you do it, you know, pre-mask, post-mask, things like that? I don't know if you can speak to any experience you might have in terms of that workflow in particular, or how much head and neck you've done, but just curious to your thoughts on that.
Yeah, so we have some head and neck doctors who are really engaged in this, and clearly bolus and fit of masks is an ongoing struggle with head and neck patients. As we know, there's a lot of different volume changes. So for us, we want to have the scan with the bolus on under the mask. So that's how we do it, which may limit, you know, which patients we use it for. But for us, that's what we do. So for the head and neck patients, we do want to have it scanned with the bolus in place. But again, that's how we do it right now. Who knows what the future could bring. I think people just have to do what's comfortable for them, even if maybe it takes a little bit of extra work or time, and then be willing to kind of review their workflow as they get more evidence, as they get more comfortable with things.
Thanks.
Great. And then moving on, you know, before you start down any path like this, you really want to have your documentation and your education. So things like checklists can be really helpful. So, you know, for patients coming at CT Sim, or even going back to that original consult with the radiation oncologist, maybe some key points or things to look for to flag using 3D bolus, or moving away from whatever your standard procedures are. And that can really help even out the effective experience, you know. So we have some really great therapists at CT Sim, and they know in their head, they know what they're looking for. But, you know, that might help having new therapists come in if you kind of write these things down and they know what to look for. Care paths. So if there's any extra steps that need to be brought into the patient's treatment plan, to identify who's doing what and what's happening, and so everybody can keep track. Also responsibilities. So, you know, in our center, it's dosimetrists here that are designing the bolus and they're doing the QA, but somewhere else, maybe that's solely a physicist job that's doing it. So however a particular center works, it's just a matter, I think, of really clearly laying out who's doing what and what's happening at these different time points. Any policies or procedures that need to be written up. And then I think the most important point in this list is the last one, which is an iterative process of, you know, feedback and improvements. So like I said, I think as a center starts, you're probably going to start out the most careful and doing the most measurements and the most checks. But as you gain evidence, it's important to kind of review things and see if any improvements in efficiency can be made, or if there's any changes that need to happen. And one thing that's worked really well for us too is to bring back these cases to the larger group. So I mentioned the value of having champions. So, you know, you might have some radiation oncologists that always think of it or that are always using it, and some that might be a little slower to come on board. So to bring cases where it's worked really well, and they're really good examples, or alternative cases where maybe we ran into some trouble, to bring that to, you know, your larger rounds or department meetings to show people and have those conversations, so that it just kind of helps keep it on everyone's radar and reminds them of how things are going and what they have available.
And you have, sorry to interrupt, you have a, just related to that and the checklist you were mentioning, you have a 3D printed tag or checklist on the requisition as well. Is that correct? Yeah.
Yeah.
Okay.
Yeah. And it can flag, those subsequent steps. So, and that might flag to, things that might have to happen at that original CT sim appointment. So it's on everyone's radar, and maybe you want the radiation oncologist there. Maybe the dosimetrist is going to come have a look. But yeah, as early as you can to flag that, it kind of helps all the subsequent downstream steps. And as far as care paths too, so like I said, we use AREA. We're big on using care paths to track all steps in a patient's treatment plan. And if we look at the different time points where, things might change or new things might happen, you mentioned on the rec, so, that RO consult. So when they see a patient, they might be able to identify them at that point in time for 3D bolus. During that CT sim appointment, that's another crucial time point. So, if you're trying to use a standard cheap bolus and the therapists are trying to fabricate it there and they're just running into trouble, it's not working, or for other reasons, they decide that, to use 3D bolus. And then also to make it clear who they can ask for help. So, if they have questions, our dosimetrists, we always have dosimetrists on site. It's a common occurrence, that they'll pick up the phone, call one of them, have them come down, look at it, to give opinion. So it's a real group effort. And then the design and fabrication. So if you're fabricating things off site where maybe that's new and you never had to do that before, to make sure that those steps get tracked. So, the 3D bolus design, if that's your dosimetrist doing it or your physicists, and then also how is that being received? So if you are receiving parts on site, who is responsible? Where are they getting delivered? Are you going to QA those? So perhaps, like I said, if they're going back on the patient for a re-CT, or if you're going to scan just the bolus itself, and, fuse that with your treatment plan. And then if there's any other evaluation. So if you aren't scanning with the bolus on the patient, maybe on day one when they're coming to the unit, maybe you're doing, an offline review of those images, or the therapists are just taking special note to give some feedback, or if anything has to change. And one thing I don't have included here is we've run into cases where a patient has a standard bolus and they're getting partway through treatment, and it's just a struggle, and the therapists are just running into a lot of problems. To have a pathway that maybe if you have to switch course and midway through treatment do 3D bolus, we've done that in the past. So just to make sure that people know these different options and what they can do.
Quick question about QC or QA of the device itself. What does that look like for you guys?
So the 3D printed boluses that we get with Adapt On Demand, they come with a pretty comprehensive QA sheet that we'll review ourselves. We'll also scan the bolus and we'll double check, for uniformity. We'll double check density, and then depending on the cases, maybe that means fusing it with whatever was used to design it to make sure that it coincides with what was expected or what was used for a treatment plan.
And do you ever use day one as a QC, of the bolus itself without doing any assessment prior to?
No, I think if we had questions about the actual device itself, we can easily take that to the CT. And for, say, like a silicone bolus, we can scan it, on part of the mold that it comes with, to have a look at it. If we weren't doing that and we were waiting till day one, then at that point, it would really just be assessing the fit at that point.
Okay. And since we have Bryson and Gosha here, who are adaptive medical physicists, I'm curious about the HU assessment aspect of it, and wondering, what other centers are asking about or performing. Are they using, literature to support the HU? Or are they just using one? Or are they, doing their own assessments? What does that look like?
Yeah, typically, it varies center to center. We have many centers that just essentially equate all bolus to water, so with an RED of 1. We have others that might choose to do a more in-depth assessment, and whether that's, CT imaging the bolus itself just to kind of get that HU value, they'll then assign it, a density based on that. And then we have some centers that'll go even more in depth and try and do, PDDs and things like that, and really try and hone in on the specific value. So it really depends on the center, the physicist there, and how comfortable they are, with the material and assigning it, whatever they find. So it varies, depending on the center.
All right. Well, thank you very much, Dr. Cherpak. Are there any other questions before we wrap it up?
I have one. Typically, most customers used to use OSLDs via Landauer. Now that whole program is now defunct, what do you suggest, for in vivo measurements? Would it be, film or MOSFETs, or, is there something else you might use? Anything that you can think of off the top of your head?
Yeah, that's a great question. I think a lot of people are in the position now of having a second look at their in vivo dosimetry program. We're doing some film measurements. It does take some care and setting things up and reading it. Things like MOSFETs, they can provide an instantaneous dose reading. That's great. Some places, if they were still using TLDs, they might use TLDs. That can take a lot of time. And if you don't already have it set up, it's a project to get those set up again. But yeah, film, I think MOSFETs, those are all reasonable options right now.
You mentioned about education in the center. It's extremely important. I'm wondering about patient education and your comment about how have patients responded to the use of 3D printed boluses in their treatment.
Mm-hmm. I think unless you're doing some kind of comparison or study, patients aren't going to notice unless you're bringing it forth to them. If you're explaining we're doing bolus and this is how we use it, then they're usually pretty accepting. When we were evaluating some silicone bolus, we did some test prints for patients that weren't using silicone. So in that case, we put it on them, trying to evaluate the fit and kind of asking them how it works and if it's more comfortable. And in those cases, they were very willing to give their feedback, and it sits more comfortably. They can tell when people are struggling to position things. So, we've had some cases where if we were just using a standard cheap bolus, they know, the therapists are coming in, they're tweaking something, they're maybe imaging, they're tweaking something again, they're moving things around. They can tell when it's stressful, and everyone's great at keeping the mood light and just getting to the end of treatment. But if you have something that you can just put on and there's no fiddling with it and you just continue on, I think it's clear the effect that would have on the patient's mental health.
Well, thank you so much, Dr. Cherpak, for providing your perspective on this topic. This provides a really nice set of steps to consider when preparing an implementation plan internally. I will note that Nova Scotia Health, as well as yourself, are part of our Centre of Excellence peer-to-peer network. So after viewing this webinar, if you have any questions or would like to talk to her or anyone else in our network, please don't hesitate to reach out to our adaptive representatives, and we would be happy to make that connection. Thanks again.
I'd be love to chat with anyone else who has questions as well. So yeah, please feel free to reach out.
Great, thank you.